Thanks, Margot. Well, that was the talk I was hoping you would give. Thanks very much. So before we introduce our final speaker, I would like to have a little shift in the program, just a little one, so that there's an opportunity to ask questions of these last three speakers. So if you, not during Tanya's talk, but during the break, can write down some questions for these three speakers. The first, say, 15 minutes or so of the question and answer session of the final hour, let's devote to those questions. Then we'll have the icing on the cake, which will be John and Sue. So our final speaker is Dr. Tanya Murphy, who's going to talk about her work on randomized clinical trials with antibiotics. Thanks.
Well, thank you for your perseverance. It's been a very informative day for me, and I hope so for you guys. Okay, got it. All right. I've had over the years some experience with using antibiotics clinically and also in clinical trials, and I'm going to kind of review a little bit of my experience on those issues. I do have some disclosures. I do Tourette's research, I do OCD research, autism research, as well as PANDAS research. So I've seen the whole spectrum, so not everything I see is PANDAS, so I do see the other types. I will be talking about antibiotics in an off-label usage. So this is considered experimental and not FDA approved. So assessing for infectious trigger. One of my little patients drew this picture of our visit, and I don't know how many people would think that a child psychiatrist, that was how their patient would see them. As, we won't go get into Freudian psychoanalytic terms, but I often did throat cultures in my office, and I have a CLIA waiver to do rapid streps. And that's a positive group A strep culture if somebody's never seen one. So what are the most common infectious triggers? Well, we've heard a lot about group A strep, and I would definitely agree that that is the most common that I see. Mycoplasma pneumonia is another one that's been reported. I'll talk a little bit about that, not a lot. And viruses are thought to be a possible trigger. And I would say that I think definitely H1N1 was a trigger because I saw a lot of acute OCD in the fall of 2009 when we had the H1N1 epidemic. And these are actually much more clear to figure out because they have the history of testing positive for H1N1 and then a week or so later develop acute onset OCD. So those are less mysterious to me than sometimes sorting out the strep and the mycoplasma connections. I know we have pediatricians, infectious disease, and so forth here. Strep is very contagious, but it's a naturally transient pathogen, so even without treatment, it'll go away on its own sometimes. Primary reason you do treat it is to prevent the autoimmune sequelae. You can get subclinical infections. About 15% has been reported, and sometimes what we have trouble with in clinically discerning is, is a reinfection what's happening, or is it a carrier state? Because you have to do a lot of gold standard kind of testing to figure that out. So what are the possible risk factors for a child developing PANS and PANDAS? Recurrent group A strep. And I did a large school study with Dr. Sweeto, and the ones that had frequent strep were actually the ones that had more behavioral problems when we would look at them in line at a school setting. I think subclinical strep infections is a risk, misdiagnosed infections, recurrent exposure, like where the brother has chronic strep, but the child never seems to develop strep. Maternal autoimmunity has been seen in 2 studies to increase the risk. Obviously, poor compliance with prescribed antibiotics for known infections. Poor antibiotic penetration into the tonsillar tissue could be a risk factor. Inactivation of the antibiotic by beta-lactamase producing organisms. lack of protective oral flora, and there's actually a couple of old studies that suggest that that might be the case for getting strep. Immunological deficits, we're finding more of these kids have immune deficiencies, and family history of rheumatic fever as a genetic predisposition to developing PANS pandas. And unlike Sydenham's chorea, where I think the idea is that sometimes the strep could precede the onset of Sydenham's chorea by 6 months, what I think happens more with PANS pandas is the infection is very close in proximity to the onset of the symptoms, the neuropsychiatric symptoms. And what I've seen in a lot of kids is that they may have had what I call a microepisode when they're about 3 years old. And a lot of times it spontaneously resolves. And then 6, 7, 8, 9 years old, they have the big flare-up that we often see clinically. So some observations that I've seen. Close exposure to strep can drive the neuropsychiatric symptoms even when the child has no signs of infection. Not all flare-ups will be strep. A few will get better without much treatment. Having high strep titers does not equal pandas, and strep titers often don't change very much over 1 to 5 months, as Dr. Sweeto has already mentioned. And a sample of children that I did for one of my trials, even without selecting for strep-induced symptoms, majority of them had some type of evidence of strep, either through exposure, infection, or high strep titers. Mycoplasma, and I don't know if this is considered controversial, but it is a very common respiratory infection. It causes community pneumonia, and it's considered walking pneumonia. Typically has a slow onset with a cough with a little sputum. It's really tricky to diagnose for sure. Quantitative real-time PCR is probably the gold standard. Elevated IgM antibodies are suggestive that there may have been a recent infection, but it is not proof. We know that it can cause autoimmune neurological disorders in a smaller number of individuals. And there have been reports of OCD after mycoplasma illness. And I know of 2 cases in my area where the child developed OCD while in the hospital for mycoplasma pneumonia. Okay, that's sort of the background of then on to treatment. One of the things, if anybody knows like psychiatric history, some of the original psychotropics actually developed out of antimicrobial treatment. Some of the TB sanitariums, they would give people these antibiotics, and they would note that their behavior would look better and they look more calm. And some of the antipsychotics and some of the antidepressants have developed in that matter. So there is some suggestion that they have some overlapping properties. Psychotropics have immune modulating properties. So maybe some of the benefit that we see in the children is because of the immune modulation properties and less so in sometimes the neurochemical properties. So I think this is something that would be really exciting, is to find how these overlapping mechanisms work, and maybe that would give us a sense of a better treatment for these children. So when you treat with antimicrobials, you're obviously treating the active infection and prophylactically the recurrence infections. So you're decreasing the antigenic load and maybe even getting rid of an occult infection. So many of these antibiotics also possess immune modulating properties, thereby decreasing inflammation and immune activation. And there are also potential for other effects. So beta-lactam antibiotics are the ones that are most studied in rheumatic fever, a very common antibiotic class. And it's interesting that Rothstein was looking for treatment for ALS, and he mined the FDA database looking for something that would work on the glutamate transporter. And lo and behold, it was the beta-lactam antibiotic class. So what he found out in some animal models is that it's actually ceftriaxone was neuroprotective and decreased neuronal damage in a motor neuron degeneration model that they were using. So it seems to be that this may be by decreasing glutamatergic neurotoxicity. And what we know is that a lot of psychiatric illnesses are now thought to be actually triggered or have involvement via glutamatergic neurotoxicity. One of the things I was interested in was in treating children. I often found that I thought Augmentin worked a bit better than amoxicillin, and other than being a more complete coverage antibiotic, why was Augmentin working better in some of these children than what you would think from just preventing infections? Obviously, it's used to inactivate the beta-lactamase producing bacteria. But the thing that's interesting from a psychiatric neurological standpoint, it readily crosses the blood-brain barrier. There's some suggestion that may increase dopamine, may decrease glutamatergic release, and this type of glutamatergic activation that occurs through these mechanisms actually may increase neurotrophic factors, making the brain heal a little bit better. The other antibiotic that we've used quite a bit are macrolides. These are bacteriostatic at low doses, but bactericidal at high doses. They're used frequently for upper respiratory tract infections, including strep infections. And they also have the triple threat of helping with Lyme disease and Mycoplasma pneumonia. Problem with the macrolides is there are pockets of non-resistance, and so that's always an issue when using macrolides. There's little data about the therapeutic effects on neuropsychiatric presentations, although there has been some evidence that you can get psychiatric side effects from macrolides, so that maybe something's going on. Specifically looking at studies on zithromycin, which is one of the macrolides, it's been found to decrease pro-inflammatory cytokines and nitric oxide activation. It promotes apoptosis or cell death of inflammatory cells. It reduces toll-like receptor 4 and IL-2, IL-12, which are both been applied in pathways involving strep. And actually, the polymorphism of TLR4 and TLR2 has been seen in susceptibility to group A strep infections. They also alter the function of antigen-presenting cells and decrease Th2 type lymphocytes and interferon gamma. So there's been 3 published studies, I think, I'm not missing one, on antibiotics in pandas. 2 were prophylactic studies. The first one, a lot of the placebo arm got treated with antibiotics, so kind of altered the results of that study. The other control study was active comparator of azithromycin and penicillin, and that one did show decreased recurrences of the neuropsychiatric symptoms. And then a case series by Murphy and Pichachiro, which is in Dr. Mink's territory, showed that group A strep was cause of a trigger in 12 children, and treating them actually led to remission of their OCD symptoms. All right. So now to the 2 little trials that I've done. The first one actually is using Ceftonir for new onset OCD in tics. And I have to preface this was not what I call PANS type of presentation. I wrote this for NARSAT, which is like a foundation that funds for chronic psychiatric conditions. And I just wanted to see if using an antibiotic would actually have any impact on these new onset presentations in children. The other reason I chose Ceftonir, besides having very good efficacy towards group A strep, is that it's not as nasty tasting as some of the other liquid antibiotics that children can take, and so it's easier to find a placebo match. They got treatment doses. This is not prophylactic doses. And they got this for 30 days. These were fairly young children, average age about 7.5. They were mostly male, and most of them had OCD and tics. Their course, although some of them had PANDAS type courses, not all of them did. There were a few with acute onset OCD and severe onset of tics, and some with episodic courses. Infectious trigger wasn't required, but upper respiratory infection or group A strep was found in the majority, although a significant amount had no evidence of an infectious trigger. And what we found was that they overall did better on their OCD severity measures, although this was not statistically significant. And the thing that was interesting is that they actually was a trend. I don't think it was such a small study, it was hard to get significance, but there was actually fairly significant improvement, clinically significant improvement in tic severity in those on active medication versus those on placebo. This is just showing percent improvement after 30 days on the YGTSS, and the Septinere was obviously much more than placebo group. Although the OCD was better, it wasn't that much better. And I know Dr. Sweeto had showed the dysgraphia that goes on with acute onset PANDAS, and this was one of the little boys that was in the Septinere study. The first one on the left shows that, his writing at that time, very, very difficult struggles, took forever to do his homework assignment. And then after a treatment of Septinere, he actually was able to quickly and neatly finish his homework assignment. So with the discussion of other triggers, I wanted to try another trial, and clinically had seen some children do remarkably well on zithromycin. So this study was designed to treat the PANS phenotype. The ages were 4 to 14 years old. They had to have a current episode of OCD, but the onset had to have been less than 6 months duration and had to have moderate severity and impairment. Exclusion criteria: no rheumatic fever, no moderate level of autism, no history of neuropsychiatric non-response to a previous medication trial, no illnesses or medications that would be contraindicated for using azithromycin, and not participating in current CBT or HRT, and of a decent weight that we could dose them okay. We enrolled 47 children, 32 randomized. There was 15 that didn't randomize, and most of those were because they did not want the placebo and wanted to seek treatment that was more active. The study was 12 weeks long in total. 4 weeks was randomized clinical trial where we were double-blinded, and 8 weeks of open label. They got the typical treatment dose of 10 mg per kilogram, and they got this every day, not the usual Z-pack of 10 mg and then 5 mg per kilogram. They all received open label probiotic twice a day, and then we had visits every 2 weeks. They had EKGs, ratings, labs, and various samples were collected. So some baseline characteristics: average age about 8, again majority male, 75% had tics, about half had ADHD. The average duration of illness was about 9 weeks, and I think the shortest duration of any of the children entering the study was 2 weeks. Average baseline SIBOX was 28.3, so they were pretty sick children. Most had sleep dysfunction. About a quarter of them had psychotic symptoms. Over half had urinary symptoms, and over half had eating symptoms. And many of them had had recent weight loss. We did some baseline labs, just kind of looking for, suggestions of markers and inflammation. Immune complexes were found in 25%, mycoplasma IgG in 59%, IgM in 19%, ASO was elevated in 41%, 62 with anti-DNase-B, Lyme, there was a 6% that screened positive, but all were negative on Western blot. 3% had a low IgG, 12% had a low IgA, a third had a high IgE, and about a 3% had low white count. So what we found was a significant difference in the OCD CGI, the clinical global impression for severity, of those receiving azithromycin versus placebo with an effect size of a little over 1. There was a 26% decrease overall with a 0% decrease in the placebo group. Many domains were better in both groups, with the active group showing the largest improvement. Adverse effects were amazingly minor, and there was maybe 1 or 2 GI complaints, but nothing like I was expecting, and no dropouts due to side effects. We did see a 10-point increase, average increase on the EKG and the QTC, so that is something that has to be considered. I don't know if you can see the bottom, but this is showing that majority of the children showed some improvement in the active group. Quite a bit of the ones in the placebo group showed no improvement. This is the mean SIBOX, or mean CGI, and this is the end of week 4. And there was a separation, and actually, if we had this by every 2 weeks, the separation occurred after 2 weeks. So their lines were very much parallel until 2 weeks, and then they separated at end of 4 weeks. The SIBOX was less dramatic. Still, overall, the azithromycin group did better. And the SIBOX is really, and I actually was wanting to see Dr. Sweeto's data on the clinical global impression and not the SIBOX. Because the SIBOX in young children, there's 16 points that they're almost all children with any OCD are going to get, just because they don't have any resistance and they don't, resistance and blanking. Yeah, so they have like control and resistance. They don't try to control, they don't try to resist. So they get about 16 points just for having any kind of OCD symptoms. And then the other issue is that one of the scores is 3 to 8 hours of compulsions or 3 to 8 hours of obsessions. So they have to go from 8 hours of obsessions down to 2.5 hours of obsessions or compulsions to have a drop in score. So it's really flawed, especially in the pediatric young age group. But that's what we have. So I had a sense that the tics subgroup, the ones that had OCD with comorbid tics, were doing better. However, we did not see any overall significant improvement on YGTSS or CGI, although 50% of those in the azithromycin group were very much improved versus 25% in the placebo group. They did show statistically significant differences in the SIBOX and also in the CGI severity scale. I'll show you some graphs of those. So this is a tic subgroup. On the clinical global impression of severity, fairly large drop in the randomized trial, and overall both groups are doing better through the course of the study. This is the SIBOX, same. There's a little bit bigger separation on the 4 weeks in the blinded phase. The tic global impression, although the azithromycin group is doing better, it's not quite as dramatic. And same on the YGTSS. Overall doing better, but not as much separation. Overall, that in the clinical global improvement scale, where that's where you're assessing how much improved they are at the end of the study, there were much more in the active group for tics than there was in the placebo group. We looked at mood symptoms, and this was a clinical global impression of mood severity. 50% of those in the zithromycin group did better versus 36% in the placebo. On the clinical global impression improvement scale, 2 subjects in the placebo group were only minimally improved. 11 subjects in the zithromycin group were minimally or much improved. Overall, these children had huge impairments of quality of life, as Dr. Tinneman, I think, very nicely highlighted. And there's a huge amount of family stress going on. And at the end of the 12 weeks, we saw a significant improvement in quality of life in the child's functioning, as well as how the parent felt about the stress and time involved in the child's illness. So for antibiotic treatment, I think that we have decent support that those on antibiotics have more improvement than those on placebo. However, after even what I consider somewhat successful immune-based treatment, many of them have residual symptoms, and these need to be addressed through other therapies, including evidence-based therapies. And I won't go into those in detail because Dr. Tinneman did such a nice job on that. And have a lot of help, and that's my research team. Thank you.
Thank you very much, Tanya. So we'll take a break for 15 minutes. And in the meantime, please write some questions for these last 3 speakers. And also, I see maybe 1 or 2 questions for our panel tomorrow. So if you have some questions for the young adult panel, please put them up here as well. So see you back in 15 minutes.